Gout. Gout is a type of inflammatory arthritis that can affect anyone. Its flare can attack one joint at a time, mostly the big toe, and can wake you up in the middle of the night. Cause. Gout is caused by too much uric acid or urate in your blood. It is a product of the breakdown of purines in your body. While purines can come from your diet, most of it is made naturally by our bodies from the degradation of dead cells. The level of urate in your body can be affected by several factors. Inherited conditions, body mass, the bigger you are, the more you produce, metabolic syndromes such as high cholesterol in your blood, high blood pressure, or late-onset diabetes, some tablets such as diuretics or water tablets. Extra urate is flushed out through urine. Yet people with gout often have kidneys that are unable to flush this extra urate out. The buildup of extra urate above a critical level can form crystals of sodium urate. The urate crystals escape from the cartilage or are deposited directly in the joint and trigger sudden, painful inflammation of the joint lining. Symptoms: unbearable pain that occurs quickly in the affected joint, often the big toe, but can also be on the ankle and wrist. Hot and tenderness feeling of the affected joints. Affected joints looking swollen, with the overlaying skin often shiny and red. Examination. The doctor may suggest 1. A blood test to measure the amount of urate in your blood. It should be less than 360 micromoles, or equivalent to 6 milligrams per deciliter. Note that not everyone with a high level of urate will develop crystals in their joints. Also, it's possible for urate levels in the blood to be normal at the time of an acute attack. 2. Ultrasound of joints can provide information to detect early signs of gout. 3. X-rays of joints will reveal joint damage in long-standing and poorly controlled gout. 4. Synovial fluid examinations involve taking fluid samples from a joint through a needle and examining them under a microscope. Along with the presence of symptoms, these tests can confirm the diagnosis of gout. Self-help measures. To help ease the pain or discomfort, some things that you can do by yourself are: lose weight if you're overweight. Avoid dehydration by drinking plenty of water. Control blood pressure, diabetes, and be cautious of raised cholesterol. Modify your diet. The things that you should avoid consuming are foods with high purine content, such as sweetbreads, liver, and kidney. Foods or beverages that are corn syrup sweetened or high in fructose. The things that you should reduce are alcohol, beef, lamb, pork, and seafood with a high purine content, such as sardines and shellfishes. Naturally sweet fruit juice, sweetened beverages and desserts, table sugar and table salt. The foods that you should consume in abundance are dairy products with low or no fat, vegetables. Treatment. Several drugs like non-steroidal anti-inflammatory drugs or NSAIDs, colchicine tablets, or steroids, either injected into the joint or muscle or as tablets, can help to treat the acute attack of inflammation. So are applying ice packs and resting the joints. Meanwhile, ongoing or longer-term treatments intend to reduce the risk of further attacks by decreasing the urate levels. For example, allopurinol or febuxostat can lower the production of urate in your body, while uricosuric drugs act to eliminate more urate through urine. If you've had an attack before, be aware of the early signs of another attack and take your prescribed treatment as soon as possible. The sooner you start treating an acute attack, the better. Outlook. Attacks can vary from person to person. Moving forward, attacks tend to happen more often and new joints are affected. A prolonged buildup of urate crystals along with the formation of hard tophi can rupture your cartilage and bone, leading to chronic arthritis. Thankfully, with appropriate self-care, along with treatments and help from a rheumatologist, the damage can be prevented and we can continue to live a prosperous life. Back pain is a common complaint in the world. It is also one of the most common reasons for people seeking medical help. The spine is a marvelous feat of engineering. For the thin structure that it is, it bears a whole lot of weight and supports the entire upper body. While usually a sturdy structure, an injury or disease may damage the bones and the nerves inside. Pain is a common way for the back to communicate this damage. Severe pain, particularly that starts abruptly and prevents the person from moving around, should be investigated on a priority basis. Clinicians refer to it as acute back pain. For example, acute back pain can be caused by trauma. The other kind of pain is chronic back pain that is longer lasting, but may not have an abrupt time of onset and may fluctuate in severity. A common reason for such pain is the degenerative disease of the spine. We have explained this in our first part. Go check it out. Some investigations that can be useful in the diagnosis of back pains include an X-ray of the spine, which is usually good at looking for bone injury, for example, fractures or thinning of the bone. MRI of the spine is also performed quite commonly these days. It has a much higher resolution than X-rays and can show the nerves, spinal cord, and the joints of the back in remarkable detail. Sometimes, the nerve conduction study, or electromyogram, may be performed to pinpoint the nerve pinched in the back. As for the treatment of back pain, most people would begin with self-medicating with paracetamol or ibuprofen. This is reasonable as long as the pain is not too severe, is not accompanied by weakness, and settles in 3 to 4 days. Continuing such self-medication for weeks and months can have deleterious effects on health, like kidney injury and stomach ulcers. Before that happens, it is better to seek help from a skilled doctor. Back pain is not a disease itself, but rather a symptom of several other diseases, so the treatment depends on the underlying disease. So, when one does end up seeing a doctor for acute or chronic back pain, the most important task is to rule out a sinister cause. The doctor may decide to treat mechanical back pain where there is no suspicion of a serious disease, with anti-inflammatory medication and physical therapy. Physical therapy can be performed with professional supervision or can be learned and performed at home. If an MRI reveals a compressed nerve or spinal cord within the back, or if the back pain is accompanied by leg weakness, one or both, and with bowel or bladder problems, the person needs to be seen urgently by a neurosurgeon. Surgery may be needed to relieve it quickly to significantly improve the chances of recovery, whether partial or complete. Delaying surgery often leads to permanent injury to the nerves or spinal cord, leading to disability. Often, severe back pain does not either have a cause amendable through surgery or the surgery itself is deemed unsafe due to the poor health otherwise. Steroid injections in the spine may be an option for pain relief. These injections have a high failure rate, and their effect usually lasts 8 to 12 weeks, even when successful. Then it may need to be repeated for pain relief. Prevention is an aspect of the back care that is often neglected. Occupational safety for physical laborers demands teaching them the proper technique for heavy lifting. Staying in shape helps to keep the back healthy by not overburdening it. At the same time, regular exercise can help strengthen back muscles, reducing the chances of further back issues. Remember, back pain is a symptom that has a spectrum of causes, ranging from benign to sinister. Severe or prolonged back pain, particularly in association with neurological symptoms, needs evaluation sooner rather than later. With good care, you can hope to rely on your back for the rest of your life. Osteoarthritis of the knee. Osteoarthritis is the most common disease that damages a joint and causes stiffness and pain. The knee is one of the most affected joints, along with the hands, hips, and spine. Condition. A normal joint is formed by 2 bones. The end of each bone is covered with a cartilage, which has a smooth, slippery surface that allows the ends of the bones to move against each other almost without friction. When a joint develops osteoarthritis, some of the cartilage covering the ends of the bones gradually roughens and becomes thin, and the knee develops swelling and pain. Symptoms. Pain, stiffness and restricted movement. Crepitus, or the sensation of grinding or creaking when the affected joint moves. Bony swelling. Excess fluid. Joint instability. Weakness and thinning of the thigh muscle. Risk factor. Obesity, high body mass, means a higher load for the joint. Previous joint injury or disease, even when already healed. Increasing age, genetic factor and gender, as women have a higher chance to develop the disease than men. Self-help. There's no cure for osteoarthritis yet, but there's a lot you can do to improve your symptoms. Lose weight if you're overweight. Exercise regularly. both muscle strengthening and general aerobic exercise. Reduce stress on the affected joint. Break the harder jobs up into chunks and do something more gentle in between. Wear appropriate footwear, for example, low-heeled shoes with soft, thick soles. Use a walking stick or walker. Use the handrail for support when going up or down stairs. Modify your home, car, or workplace to reduce unnecessary strain. Don't keep your knees still in a bent position for too long. Apply heat or ice packs. Use painkillers or anti-inflammatory creams, gels, and tablets. Remember to read the label first. There are some medications that don't have a proven role yet, but are still used, such as glucosamine and chondroitin, and also acupuncture. Treatments. If you still have pain after trying self-help measures, seek help from a rheumatologist. The rheumatologist would examine you and advise you to go for an imaging test like X-ray or MRI, or take your joint fluid for analysis. If required, a rheumatologist may recommend the following treatments: stronger painkillers, steroid injections into the painful joint, capsaicin cream. Always follow your rheumatologist's advice for the proper dose and duration of the medicine. A surgery, including joint replacement, may be needed for intolerable pain. Ankylosing spondylitis is an autoimmune inflammatory disease that mainly affects the spine on your back. It's a type of inflammatory condition, among others, known as spondyloarthritis. As a part of the body's mechanism of inflammation, the ligament that attaches to the vertebrae receives calcium. This causes the bone cells to grow from the sides of the vertebrae. Eventually, the individual bones of your spine may fuse and lose flexibility. This is called ankylosis. It often starts in your late teens or 20s. Related conditions. Some conditions that can be confused with ankylosing spondylitis are non-radiographic ankylosing spondylitis, undifferentiated spondyloarthritis or USPA when the disease is still in the early stage, psoriatic spondyloarthritis, enteropathic arthritis, reactive arthritis, juvenile idiopathic arthritis. Symptoms: stiffness and pain in your lower back in the early morning, which eases through the day or with activity. Pain in the joints where the base of your spine meets your pelvis. Tenderness at the base of your pelvis. This makes sitting uncomfortable. Some may have pain, stiffness, and swelling in their knees or ankles. Enthesitis or inflammation that occurs at any point where tendons or ligaments attach to bone, for example, at the elbow and heel. Tenderness at the heel. Pain and swelling in a finger or toe, known as dactylitis. Chest pain, tiredness or fatigue. Inflammation of the eye, such as uveitis or iritis. Please note that ankylosing spondylitis is not contagious. A gene called HLA-B27 is present in people with ankylosing spondylitis and can be detected by a blood test. However, this gene doesn't mean you'll definitely get ankylosing spondylitis. Only 1 in 18 people with the gene will actually develop the condition. Diagnosis. No single test can be the gold standard to confirm that you have ankylosing spondylitis, so the doctor may need pieces of the puzzle to diagnose, such as the history of your condition, a physical examination, blood tests, for example, the erythrocyte sedimentation rate, or ESR, which may show inflammation, C-reactive protein, or CRP, blood test for HLA-B27 gene. X-rays can confirm the diagnosis, but only if the disease has reached the latter stages. MRI scans may show the typical changes at an earlier stage of the disease. Treatments. Exercise and pay close attention to your posture. Drug treatments, for example, 1. Painkillers and NSAIDs in the form of tablet or gel are usually the first choice of treatment. 2. Disease-modifying anti-rheumatic drugs like sulfasalazine. They work slowly, so you may feel no change in your condition, but they make a big difference to your symptoms over a period of time. 3. Biological therapies like anti-TNF drugs are newer treatments that can be very effective, like etanercept. Your rheumatologist would guide you if you need them. 4. Steroids, used as a short-term treatment for flare-ups. They're usually given as an injection into a swollen joint. Physiotherapy, to exercise your back and neck to avoid them stiffening into a bent position. Surgery is not required for most patients, but can be recommended for some. Things you can do: massage and acupuncture. If your heels or feet are affected, place orthotics inside your shoes. Try a hot bath before going to bed. Use a medium firm bed. Putting hot or cold pads. Try to keep the number of pillows to a minimum. Stop smoking. Pay special attention to your posture. However, contrary to usual sickness, bed rest is bad, as this will speed up the stiffening of your spine. If you have ankylosing spondylitis, there's a small chance, around 15%, that your children will also develop it. If you think your child or another relative develops the symptoms, ask them to consult the doctor, as the disease may run in your family. Cervical spondylosis. Overview. Cervical means our neck area. Spondylosis means a degenerative condition affecting our spine. Our neck consists of these parts. A. Bones. Your neck is a part of the spine, which makes up the top 7 out of 24 bones, called vertebrae, that are stacked on top of one another. The shape of these bones creates a hollow part that protects the spinal cord. B. Spinal cord and nerves. These wires go through the spinal canal to send signals between your brain and other parts of the body. From the spinal cord, the nerve roots rise out through openings in the vertebrae or foramen. C. Joints. There are 3 joints between each pair of vertebrae. The joint in the front is the intervertebral disc, which are the flexible pillows filled with jelly. They help to absorb the shock when you walk or run. The 2 joints in the back are the facet joints. There is a cartilage in each joint to cushion the ends of the bones. There are also ligaments, the soft bands of tissue to bind and strengthen the vertebrae together. Cervical spondylosis is the natural wearing down of these parts of the neck as we age. These changes happen in everyone, as they are normal. More than half of middle-aged people and older have worn down discs that may not cause noticeable symptoms. These weariness can include dehydrated discs. By the age of 40, our spinal discs begin drying out and shrinking, resulting in loss of disc height, which risks more bone-on-bone contact between the vertebrae. Herniated discs. Herniated or bulging discs may appear from the crack. Bone spurs. These are grown in a misguided effort to strengthen the spine. Facet joint arthritis. It is caused by increased pressure and the degeneration process. Stiff ligaments. Spinal ligaments can stiffen as you grow older. Your neck will become less flexible. Risk factor. Age. The condition is common around 80% in patients who are 40 years and older. Occupation. Jobs that involve repetitive neck motions, awkward positioning, or a lot of overhead work put extra stress on your neck. Previous neck injuries. Genetic factors. Individuals in certain families with a history of neck pain will experience more of these changes over time. Smoking. The nicotine inside can affect the blood supply to your neck. Depression or anxiety. People with anxiety are prone to bad posture due to their negative moods. Being overweight and inactive. The added pressure can cause a strain in many parts of the spine, including the neck. Symptoms and alarming signs. For most people, cervical spondylosis shows no symptoms. When it does, the first ones typically are pain and stiffness in the neck. This pain may develop gradually or occur suddenly, and usually improves with rest or lying down. Other symptoms may include headaches, the sound of grind and pop when your neck is turned, muscle spasms in the neck and shoulders. If the symptoms do not go away after a few days, you could try to visit your doctor. However, if any of these alarming signs appear, then you must not wait. You have a tingling or numbness sensation in your hands, legs or feet, lack of coordination and difficulty in walking, loss of function of hands, like having problems in writing, loss of bladder or bowel control. The alarming signs may be the result of the pinch from your neck bones to the spinal cord, called cervical myelopathy, or to the nerve root, called cervical radiculopathy. It is also an urgent condition if you experience dizziness or blackout when turning your head or bending the neck, because it means the vertebrae artery, which supplies the brain, is affected by the degenerative change. Now, what is treatment available for your condition? You may need to undergo physical therapy or even surgery under certain circumstances. We'll explain more in the next part of this video. Our bodies and their movements are greatly aided by the joints and bones. However, some conditions can hurt the joints and bones. We have discussed gout and arthritis, which affect the joints, in our previous videos. Now, we will talk about osteoporosis, which impacts the bones. Bone is a living tissue. It constantly revamps itself by growing new cells and breaking down the old ones. If the growth exceeds the breakdown, then the bones will improve. Like during our childhood, when our bones grow stronger, and our adolescence, where our bones grow longer and we become taller. The bone density peaks between 20 to 40 years of age. But when the balance shifts and the breakdown outdoes the growth, our bones become compromised and lose their density. Osteoporosis is a condition when our bones become less dense and become very fragile. It shows no symptoms and develops slowly in the background over the year. That is, until a common fall or simple impact suddenly breaks your bones. Unlike Paget's disease, which usually only affects a single bone or is localized in an area, osteoporosis is spread to all bones of our body. Risk factor. Women are more likely to suffer from osteoporosis, especially after their hormones change during menopause or postmenopausal osteoporosis. Osteoporosis runs in your family. A child with a genetic disorder can also suffer juvenile osteoporosis. Bad habits, such as drinking, smoking, and rarely exercise. Having a low body mass, with a body mass index less than 21. Receiving steroid treatment for 3 months. Self-help. The following advice can help you reduce the risk of osteoporosis. Add plenty of calcium and vitamin D as part of a well-balanced diet. They can be obtained from dairy products such as milk, cheese, and yogurt, along with milk made from soy, rice, or oats. Do exercise regularly, especially resistance training using dumbbells or posture training such as Tai Chi. Quit smoking and drinking if you are still doing them now. To treat your osteoporosis, you can consult with a rheumatologist. To diagnose, they would advise you on a particular test called DEXA scan for diagnosis. This test measures bone density. The possible results are normal, so the risk of a low-impact fracture is low. Osteopenia, which means that you have a small risk of a low-impact fracture, but your bone is already weaker than the average one. Osteoporosis, which is when you have a greater risk of low-impact fractures. Discuss this with your doctor as you may need treatment. This test is done before starting treatment and can later be repeated at 2 to 5 year intervals as per your doctor's advice. Treatments. Bisphosphonates, such as zoledronic acid treatment, will prevent bone resorption by binding to the bone mineral and induce apoptosis of osteoclast. Teriparatide, which is a synthetic, simpler human parathyroid hormone. It will promote the growth of the bone by decreasing bone turnover. Raloxifene, which has the benefit of estrogen hormone without its drawback, can treat postmenopausal osteoporosis. Denosumab, a monoclonal antibody, prevents the maturation of osteoclast. Treatments such as strontium ranelate are under scrutiny due to their dangerous side effects. All of them will help to increase the BMD or bone mineral density. After receiving treatment, inform your doctor whenever you encounter gastritis, which is the most common side effect, skin rashes, sore mouth, flu-like symptoms, jaw pain, headaches, and nausea. Remember, bone renewal is a slow process. Even though you won't be able to feel whether or not it's working, your bone density should start to improve after 6 to 12 months. Your doctor may suggest a break from your treatment after 3 to 5 years, but the effect of the treatment will still continue later.
Everyone may have had some form of hip pain in life. The stiffness and discomfort on the hip joint when moving the body, that's even experienced by a tough guy like Arnold Schwarzenegger. But replacing your entire hip because of it is something else. Is a total hip replacement surgery necessary for your hip pain? To know the answer, let's have a close look at the hip anatomy. Our hip is a ball and socket joint that consists of two parts. The femoral head, which is a ball-shaped structure at the top end of the femur or the thigh bone, and the acetabulum socket in the pelvis that fits perfectly to the femoral head. Both surfaces are covered with a smooth and slippery connective tissue called the articular cartilage. The joint structure is confined by synovial membrane, whose fluid lubricates the cartilage. Together, the articular cartilage and the synovial fluid helps reduce almost all friction, thus allowing smooth movement. However, this ideal condition may not last long. Osteoarthritis, or wear and tear type of arthritis, may cause elderly or people with a family history of arthritis to experience hip erosion. In this erosion situation, the uneven cartilage surface cushioning the bones of the hip increases the friction of the bones and causes hip pain and stiffness. Hip pain caused by arthritis in the early stage is preferably relieved by non-surgical treatment, such as drugs and nutraceuticals, physical therapy, injections, assistive devices, and lifestyle change. But if the pain is intensifying, reducing mobility and interrupting everyday tasks, then it is time to consult your doctor for the surgical option. Beside osteoarthritis, other conditions that cause hip pain are rheumatoid arthritis. This is an autoimmune disease in which inflammation happens as the immune system attacks healthy cells, mistaken as foreign substances. It is characterized by swollen synovial membrane and cartilage erosion, leading to the damage of the hip joint. Post-traumatic arthritis. This is a type of arthritis as a result of a serious hip injury or fracture. Osteonecrosis, or also known as a vascular necrosis, is the death of the femoral head due to the lack of blood flow. The blood flow disruption can happen because of hip fractures, hip dislocations, or certain medical conditions and treatment. Childhood hip disease. Some children and teens may encounter particular hip problems, such as Legg-Calvé-Perthes syndrome and idiopathic juvenile arthritis that may affect their later life, and therefore may need hip replacement. After being physically and mentally prepared for surgery, the patients have to be sure that they're willing and allowed to leave work or school for at least 6 weeks, and most importantly, have a good physiotherapist. There is no age or weight limit for this procedure, even though the average age of patients who undergo incisions are aged around 60 to 80, with very infrequent surgery on teens and young adults. Surgical routes are decided based on the severity of joint damage and the condition of the patient. For patients with mild damage on the femoral head, especially younger ones with higher activity like athletes, doctors tend to suggest the hip resurfacing procedure. This procedure trims the damaged femoral head and then resurfaces it with metal covering. When the injury or disease affects the femoral head way more than just mild damage, then surgeons perform a partial hip replacement, where they replace the damaged femoral head with a prosthetic whose stem is embedded into the femur. But when both the femoral head and the acetabulum are severely affected and cannot function properly, surgeons need to perform a total hip replacement, where the acetabulum is also replaced with a metal socket. Before performing hip replacement, the orthopedic surgeon requires the medical history, physical examination, X-ray, and sometimes MRI or CT scan of the patient to determine the extent of the joint damage. The current medication should be informed if there is any, and some of them must be stopped a week before the replacement, such as aspirin, anti-inflammatories, blood thinners, and supplements. Patients also need their dental problems solved before surgery to prevent germ infection on the joint. Quitting smoking and limiting alcohol intake is helpful to reduce any post-operative complications. Additionally, it is recommended to take exercises for hip muscle strengthening before surgery. For a better recovery period and experience, prepare a recovery room at home while keeping things in reach. Now, we are ready for the details in the operating room, which become our main discussion in the upcoming video, so stay tuned.
You remember that big ouch moment in football games? Or soccer, I got you. When one of the players tackles skillfully right into the knees of another player, bending it into an unnatural pose. Or when there's a player who makes a drastic stop or turn in the middle of a run and ends up rolling over the field, writhing in agony. These types of scenarios usually cause the anterior cruciate ligament, or ACL, to be torn. What is torn ACL? To understand the torn ACL, we need to learn a little bit about the anatomy of our knee. Our knee consists of 3 bones: the femur, or thigh bone, the tibia, or our shin bone, and the patella, or the kneecap. They are stabilized and held together by the ligaments. The collateral ligaments, like the medial or MCL on the inner side of our knees, and lateral or LCL on the outer side. prevent the knee from bending out of position. Then there is the posterior cruciate ligament, or PCL, and the anterior cruciate ligament inside the knee joint. They control the back and forth motion of our knees and also provide rotational stability. Lastly, the cartilage, such as the articular and meniscus, along with the quadriceps and hamstrings muscles, are there to help articulation of our knees. So yes, this ACL is the part that is affected by the injury. Risk factor. Some factors may increase the risk of ACL injury. Females naturally have higher risks due to the difference in muscle strength and hormonal influence. Doing particular sports like football, American football, basketball, gymnastics, and downhill skiing. Wrong movement, such as moving the knees inward when doing squats. Poor conditioning before doing sports. Playing on unsuitable or poor quality turf. Wearing loose shoes or other equipment. Causes. Injuries to ACL are not only sustained by professional athletes, but by people doing recreational sports as well. It can be caused by several of these reasons. 1. Receiving a force or blow to your knees, for example, during a sliding tackle. 2. Pivoting or turning when your foot is firmly planted. 3. A drastic change to your running speed. 4. Landing awkwardly after a jump. Type of injuries. Injured ligaments can be graded depending on the condition after the injury. Grade 1. The ligament is mildly damaged and stretched, but can still help stabilize the knee. Grade 2. This rare grade has a ligament that is stretched far enough until it becomes loose, also called a partial tear. Grade 3, known as the complete tear. The ligament splits into two pieces and the joint becomes unstable. The avulsion of ACL is when one of the ends of the ACL is detached from the bone. This one is more common in kids. In extreme cases, such as when the blow to the knee happens when the foot is firmly planted, the three important structures of the knee, the ACL, MCL, and meniscus, would easily be torn apart by the impact. This has always caused debilitating pain and a serious amount of unhappiness, granting it the name of unhappy triad injury. More info about first aids and diagnosis are upcoming in the second part of this video. The ACL injury of the knee, due to high impact movements, rarely happens unnoticed. At the exact moment of the injury, a popping sound might be heard, and your knee may limp soon after. If you suspect this is an ACL injury, put your leg above the heart and put ice on it. Do not use it to do any activity, and directly see your doctor to get a complete observation, especially if a bluish area appears or your feet become cold, which means that the blood vessels to your knee is injured. Within 24 hours, your knee will swell and become painful. The knee will lose a wide range of movement. Tenderness along the joint line and discomfort while walking are expected. The swelling and pain eventually resolve on their own, but is still unsafe for use in sports activity, which can risk further damage to the meniscus on the knee. Diagnoses. The doctor will ask about how your knee can become damaged. Physical examination and comparison with a healthy knee can help. The Lachman test will determine whether your ACL is still intact or not. Special tests can also show that other ligaments are still in their place. X-ray imaging helps to show if any damage to the bone is visible. MRI creates better images for soft tissue, such as the ACL. Non-surgical treatment. For lower grade or partial injuries on the ACL, or when the knee is still stable, this treatment is favorable, especially in children, as surgery may damage their bone growth plate. People with previous physiological problems in their knee should also opt for non-surgical treatment because the surgery may carry more risks. The non-surgical treatments include using a brace to protect and stabilize your knee. Crutches are needed for a while to prevent your knees from bearing too much weight. Physical therapy can start as soon as the swelling of the knee goes away to promptly restore your knee's function and strengthen the leg's muscles. But the damaged ACL disables your knee from returning to its former condition and swift movements. To support an active lifestyle like football athletes, the damaged ACL needs to be reconstructed to prevent joint instability, further injury to other parts, or osteoarthritis in the future. Our next part of this video will discuss it.
Anterior cruciate ligament. A piece of tough band in the knee is so crucial for jumping, running, and turning, its injury used to end an athlete's professional career. For a condition as severe as it is, torn ACL is surprisingly not uncommon. It happens around 250,000 times a year in the US alone. Most of them are due to sports injuries, but they can also be caused by accidents or falls. Fortunately, current medical advancements have given a way for people with ACL injuries to resume his or her active life or fledgling sports career by undergoing the ACL reconstruction surgery. Torn ACL will not heal, even if stitched, as it's covered in synovial fluid which prevents it from getting access to blood and oxygen to heal itself. So, a comparable living tissue is used as a graft to replace the torn ACL. The graft is generally harvested from the patient's own tissue, called an autograft, such as from the patella tendon, the hamstring tendon, and the quadriceps tendon. However, if the stability of the tissue around the knee cannot be compromised, taking an allograft from a defrosted cadaver or using a synthetic graft may otherwise be necessary. Before the surgery, make sure the pain and swelling in the knee have lessened and the patient is able to do a normal range of motion. This is prior to the 3 weeks of low-intensity physical therapy required to strengthen the muscle. The doctor should ask for the patient's ongoing medications or supplements, as some medications, such as blood thinners, may increase the risk of bleeding. No food and water were allowed 2 hours before surgery. During the surgery, general anesthesia may be used, especially on the knee to decrease postoperative pain. The surgeon then begins to examine the knee to verify the torn ACL and check the condition of other ligaments and components as soon as the patient relaxes. After preparing the suitable graft, the surgeon starts a minimally invasive procedure called arthroscopy. Small incisions called portals, around 1 centimeter wide, are made in the front of the knee. One is for the arthroscope, a tube with a camera and a light source to visually guide the surgeon. The others are for the surgical instruments to access the joint space. The torn ACL stump is removed using a shaver, which is also used to clean up the area or adjacent parts, such as the meniscus. Using a special drill, bone tunnels are made to the thigh bone and shin bone in order to place and hold both ends of the graft. The sutures for the graft are tied to a long pin to be passed through the shin bone to the thigh bone tunnel. After attaching the graft, the surgeon pulls the suture and places the graft into position right where the old ACL was. Then, interference screws, spiked washers, or staples are used to secure the ends of the graft and fix it in place. The tibial end of the graft is first put under tension and secured afterwards. As the screws and sutures are biocompatible, they're handily absorbed by the bone, eliminating the need for removal surgery unless there's a problem. Finishing the surgery, the surgeon will probe the graft to make sure it has good tension and test the stability using Lachman's test. The skin is then closed and dressing can be applied. As we wait for the patient to recover after the surgery, we'll discuss the treatment and prevention in the next video.
Thank you for your continuous support, especially our valued patrons and members who have been encouraging us to keep producing more quality content.